Thank you very much. Good morning, everybody. So my name is Chris Taylor. I'm an elderly care reg at the Royal Victoria Infirmary in Newcastle. And last year I had the opportunity to be an education fellow in medicine at Whipps Cross, which if there's any trainees interested in doing that is an absolutely great job. And during that year we looked at a project to improve leadership and non-technical skills, predominantly amongst junior doctors, using a modified rapid cycle deliberate practice approach to simulation, which sounds like a bit of a mouthful, but hopefully in the next 10 or 15 minutes all will become clear. I don't have any conflicts of interest declared, however it's not entirely all my own work. It's part of the team at the Medical Education and Training Suite at Whipps Cross, so they were all involved with this project, so the credit goes to them as well. So in terms of why we were actually doing this, leadership within medicine and healthcare is receiving increasing attention, particularly over the past 5 to 10 years. But actually what we're seeing, as you can see from those headlines, is that leadership within the NHS often is highlighted because of its failings and because of various healthcare problems that we've had within the UK recently, and that's been no more obvious than in the Francis report, where his main criticisms of what happened in Mid-Staffordshire was that there was no evidence of leadership, and that was a significant contributing factor to what happened there. What we also know is that leadership within healthcare and good healthcare leadership helps to improve efficiency and quality of care for patients. But for something that is so important and something that it really carries such significant weight for patients and the care that they receive, doctors within their training don't often receive any formal leadership training and don't often even really know what healthcare leadership truly is. We also think about non-technical skills, which is something that's been discussed extensively already so far this morning, and this is not going to be the last time that you hear about it, but non-technical skills and human factors we think are probably responsible for about 50 to 80% of healthcare errors when they're lacking. So a significant amount of serious harm coming to patients is all because of a deficiency in non-technical skills and human factors. But again, when you speak to UK medical graduates and international medical graduates, a high percentage of them have never actually heard of human factors before. And for something that's so important and the way that it affects the way that our patients are looked after, I think we should really be paying a bit more attention to it within education for these people. So, what we aimed to do really is to try and improve non-technical and leadership skills, predominantly amongst junior doctors, and by doing this in an accessible and practical setting. Now the question is, how are we going to do that? Well, the answer obviously using simulation, but we're trying to remove the focus and the anxiety associated with technical skills within this setting. And we know that within simulation, lots of people that attend these simulation sessions have significant performance anxieties, and that's mainly around technical skills and getting things wrong. So what we wanted to do is to try and avoid the focus from being on these technical skills so that we can focus on human factors and the non-technical elements of these sorts of scenarios and really concentrate the learning on that. Now the way that we did that was by using what we call a modified approach to rapid cycle deliberate practice. Now, rapid cycle deliberate practice really originated within sports and music, and particularly originated in golf, with professional golfers. And the aim with deliberate practice is it's purposeful practice with a specific end goal, interspersed with regular feedback and repetition, so that you can highlight what the erroneous behaviour is, and then you can correct it with external feedback, and then practice that new learned behaviour so that it's ingrained. And the aim of what we're doing is you're trying to take people from novices to being proficient at something using this approach. Now, within healthcare, there's a pediatric intensivist in Baltimore in America called Elizabeth Hunt, and she applied this concept to resuscitation simulation and actually to technical skills within pediatric resuscitation. So what we're aiming to do is somebody arrives who is a novice, they then perform a certain task, they receive instantaneous feedback, which is brief and succinct, which highlights their errors. They can then repeat that task using that information and help to ingrain those new learned behaviours so that they can then become a competent performer at that task. They then receive further feedback about their performance again, highlighting areas for improvement, and they then repeat the task again so that they're competent and proficient at doing that. Now, this is in slightly different terms to traditional simulation training that we know, where candidates go and do a simulation session. They are then debriefed by trained faculty, and we then hope that that will lead to future improved performance. But we can only hope that. We don't necessarily know if that's actually going to lead to improved performance at that point. So what we designed was a one-day simulation course, which would typically aim to have around 5 candidates, sometimes more. The day begins with a morning of interactive seminars, and we base these around the concept of non-technical skills, leadership and crisis resource management. So for people that haven't really encountered these concepts before, they're getting a bit of an idea about what it is that we're talking about and what we want them to be focusing on throughout the day. In the afternoon, we then have 5 simulation scenarios, and they all have the same technical elements, and this is the key point about this whole project, what we've been doing. The technical elements always stay the same, and on the next slide you'll see what I mean. All of the people that are involved within the actual simulation scenarios, apart from the leader, which is the candidate, are all played by trained faculty, so that's to keep the environment as controlled as possible for learning. So this is the outline of the afternoon and the simulation that we use. So we usually have about 5 candidates, so 1 candidate per simulation. The first scenario that we have is an elderly gentleman who's been complaining of cardiac chest pain is then found unresponsive with no pulse, and they are asked to lead the cardiac arrest algorithm for a shockable rhythm. So it's a reasonably straightforward scenario. All candidates that attend this day have to be ALS trained, so they have the underlying technical skills to be able to do this appropriately. Following that scenario, they are debriefed as a group by the trained faculty members that are there on the day, and we're very keen to emphasise that this is the technical element, and this is the only technical skills that are going to be involved throughout the day. We summarise the non-technical skills that have been exhibited and discussed and shown within that simulation setting, and also highlight some of the things that we want to be seeing from the candidates during the rest of the afternoon. So at this point, candidates are very much a novice group. So they witness one of their fellow colleagues doing this scenario. They're running the shockable cardiac arrest algorithm for ALS. They're all trained in it. They all know how to do it. From this point, we then start to increase the complexity. And we start to increase the cognitive load that's placed on the candidates that go into these simulation settings. So in the second scenario, it's exactly the same as the first, but we then start to put in some confounding human factors. So we have a disruptive colleague, and I'm slightly aware of the audience that I'm speaking to, but we have a disruptive anaesthetist who is particularly focused on intubating the patient and disturbing chest compressions. And everybody knows from the ALS guidelines that chest compressions are the most important thing in terms of restoring cerebral perfusion. And it's all about how they manage that interaction between the anaesthetist, who's challenging that leadership role, and the way that they approach that, which is all non-technical skills and human factors. It's not technical knowledge, it's about how they interact with people. So following that scenario, there's a debrief by the faculty, obviously explaining and discussing everything that's been done and what's been highlighted, with feedback about what could be improved or what could have been done differently to make that scenario run better. And we're treating the whole group as a group of learners together so that we can try and improve their skills and their proficiency from being novices to being competent. Our third scenario, again, the technical element is exactly the same. So it's the same cardiac arrest algorithm, but this time the confounding human factor is a disruptive fellow patient. So we have a character called Paddy, who is a withdrawing alcoholic, who is hallucinating, he's very physically and verbally aggressive. And he's trying to get involved with doing chest compressions and trying to play around with the defibrillator. So we then have an environmental risk both to the people involved in the scenario as well as the patient themselves. We've got live electricity, obviously, when you're defibrillating somebody. So it's all about how they manage that and how they use their resources and their team members to manage that confounding factor with an aggressive patient. After that, again, we also have short debrief discussing what we found, the behaviours that have been exhibited and how we can go about approaching that in the future. And then we move on to our fourth scenario. So this is where we then start to ramp things up a little bit more. So we're increasing that cognitive load, making it more complex. It's a lot more difficult to manage from a non-technical aspect. And the scenario, the technical element is the same, but we have an incompetent junior colleague. So there's a foundation year 1 doctor who's just started. It's the first week in August. They've never been to a cardiac arrest before. They don't know what they're doing. They don't know how to take blood properly. They can't get venous access. They're not sure which drugs to give. So it's all about how you manage that character within that scenario and how you go about dealing with a colleague in difficulty, which is something that we do see quite frequently in real life. Following on from that, as I'm sure you're probably aware by now, we then do another debrief. So we're going through that rapid cycle type approach with continual debriefs about non-technical and human factors. And then we move into our final scenario where at this point we expect that our group are reasonably competent at these non-technical skills and human factors that have been discussed so far. So you can't teach human factors in a day, but what we're expecting is that by this point our candidates will start to have a lot better skill repertoire just from watching, learning from osmosis and discussion during the debriefs. When we go into the final scenario, so lucky person number 5, they have to deal with an environmental crisis. So the technical aspect is exactly the same as I was saying before. It's the same algorithm, but as they're starting to try and resuscitate this patient, smoke starts to come into the room, and we also have an active fire alarm. So at this point, it's about decision making, team management, being able to discuss things with your colleagues. Is it appropriate to leave? Do you move the patient? All these sorts of things and human factors, people interaction that they have to discuss in order to complete that scenario. That's then finally followed by yet another debrief. We're trying to highlight and reinforce the behaviours that have been discussed throughout those sessions. So in terms of the people that we've had attend the course, certainly while I was helping to run it, we had 34 participants. We'd run 6 one-day courses, an average of about 5.5 people attending per day. The vast majority of those that attended were senior house officers, so anybody from F2 through to CT2, CT3 level, people who are on the wards constantly seeing these sorts of things. We had 7 registrars attend. We also had a diabetes and endocrinology consultant that attended, but I don't think she got what she was expecting. And we also had 4 senior nurses from critical care and coronary care backgrounds. And we also had 2 foundation year 1 doctors as well, so they're starting to think about these sorts of skills early on. We asked people that attended a number of questions prior to coming to the simulation day, just to try and get a bit of a gauge about what sort of experience these people had had before. Admittedly, we had a variable success at ensuring that we actually got the data, so we had 23 out of 34 respondents. So 19 out of 23 people that attended had never had any training in clinical debriefing. And again, 19 out of 23 had never had any training in leadership skills. And 18 out of 23, most importantly, had never ever been given any feedback on their own leadership skills. And if we're talking about this being such an important thing and such a big contributor to patient care, why is it that people aren't knowing what skills they have and how they can improve them? We also, after the course, asked candidates a number of questions about how they thought the day would prepare them better or worse for future practice. We had 28 respondents. So the vast majority strongly agreed that it's relevant to current medical practice. I'm sure you probably all agree that it definitely is. Most of them thought that education on non-technical skills improved teamwork. We also found that a lot of them thought that enhancing non-technical skills improved patient care. They felt that the course improved their own leadership skills, and also that the course improved their ability to debrief a critical event. So we're also trying to prepare people for if they witness these sorts of things in the future, how they can make team learning better. And obviously debriefing something after a critical event like a cardiac arrest is something that's very important. We also asked what people thought generally about simulation, but also leadership simulation. And 23 out of 28 respondents had significant anxieties in advance of doing simulation training. But one of the things that we were most interested in was keeping the technical elements the same throughout. Would that influence the way that their anxieties came across? 24 of the 28 respondents felt that actually it reduced their level of anxiety throughout the day, keeping the technical element the same. And when you ask people what they think about this, they often say that they don't want to get things wrong in front of their colleagues, they don't want to look stupid, they don't want to look as if they don't know what they're doing. But if we keep these technical elements the same, we can really focus on what we're actually trying to do here, which is focusing on communication, teamwork, crisis resource management, things that aren't commonly taught, but things that are very important amongst these sorts of people. So, what can we say from what we've done so far? We know that junior doctors have got very little formal training within leadership, and also non-technical skills and human factors. And we also know that they have very little feedback as to their own performance in these domains in the clinical setting and how they can go about improving their own skills. We've seen that a modified rapid cycle deliberate practice approach, combining traditional simulation with this new approach, can be an effective modality for teaching non-technical as well as technical skills. Keeping the technical element the same helps reduce performance anxieties, and we also can say that candidates value non-technical skill simulation and a group discussion of non-technical and human factors and leadership during debriefing. And thank you very much for listening, and I'm happy to take any questions.